So we're just going to close this out for a second. All right. Yeah, you still hear me?
Yep, I can hear you.
All right, I'm going to check Instagram real quick, make sure we're live on there. You're going to be on mute for a second. All right. It's about 4 o'clock now. Let's see if Rick or anyone else is on yet. Oh, hey, Rick. What's up, man? How you doing?
Hey, how's it going?
Good, man. Good. I don't think Randy's going to be able to join us, but we are live on Instagram and YouTube right now. I guess everyone's here. We got Simon as well, and Dan's here. Oh, Dr. Sheehan's here. Let me pull him in. Give me 1 second. So I have like 4 devices running simultaneously to make this happen. All right, cool. Just make sure we're live on Instagram.
Hey, good afternoon.
Hi, Dr. Sheehan, good to see you.
Nice to see you.
Hey, Jason, what's going on?
It's good to catch up with you all.
Hey, Dr. Sheehan.
Sounds,
So I guess,
it sounds like Randy's not going to be able to join us.
yeah, it sounds like Randy's got a pretty interesting case going on. So since it is about 4 o'clock, we are live on everything right now. Maybe we can get started. So welcome back to another edition of Tumor Talk, everyone. On this week's episode, it's a very special episode, especially for me. We have Dan Eichberg and Dr. Ricardo Komitar from University of Miami here, along with special guest Dr. Simon Hanft and, of course, Dr. Jason Sheehan, who's here from UVA. We're going to be talking about a new book that was recently published. It's a pretty hot book right now. I've read through it, and I think it's kind of amazing. Surprised that nothing like this has come out so far, and it sort of goes over the business of brain tumors. Dr. Eichberg and Dr. Komitar put this together along with a couple of other authors and editors, some who are on this Zoom link here. But I just want to maybe spend maybe the first third of this on going over the foundation for the book, where you guys got the idea, the sort of demand for it, and sort of along those lines.
Yeah, I just wanted to interject one thing, and that as we speak, I just pulled it up. #1 new release on Amazon for neurosurgery books. So it's more than hot. It's risen to the top. So, but go ahead, Rick. Give us your insights and how this sort of came about.
Sure. This all came about. I've given a bunch of visiting professor talks around the country, and I'm sure Jason knows that when you give a visiting professor talk, you're always wondering, what's your niche? Are you going to be talking about research, or are you going to be talking about building a practice? Are you going to be talking about lab research or organized neurosurgery? And I something that I'm most comfortable with, and something that really is my strong suit, is kind of building a practice and stuff that we've done here at Miami. And so after having given a bunch of visiting professor talks around the country, it just came to mind that this should be in writing, because every program that I gave the talk at, there was such positive reviews, and it was really accepted so well that I thought we should put it into a book form. Dan, who did our Infolded Brain Tumor Fellowship just a few years ago, is an outstanding resident, not only clinically, but also academically. So we got Dan involved. I sent him my PowerPoint for my visiting professor talks and a little bit of guidance about the techniques that I use. And within a few weeks, Dan just ripped out this book. So it was kind of amazing. And then with just very few edits going back and forth, kind of fine tuning, then we had a version that we could send to the editors. Obviously, Simon and yourself are on the editorial board. You guys have been a huge advantage having you guys, edit the text. And then the final format just came about a few weeks ago. So obviously a huge team effort. Everyone's been involved, but really kudos to Dan, who helped put the book together from scratch.
Well, thank you. And Rick, it was your, you're the one who did it. It was your presentation and your guidance that really made it possible. And just sort of from a basic, for people that don't know about the presentation. So when you're a resident like me, you go to the hospital every day and you operate, and the cases they just appear for you. But then when you graduate, those cases don't necessarily just materialize for you. You realize that you have to do some additional work in order to convince patients that you're the best surgeon for them. It's a real question. How, as a new attending, are you able to convince people to see you instead of seeing somebody who has much more experience? And that's a sort of a topic that isn't really covered in residency training. So we really felt that this need had not been met. So that was the kind of impetus for writing this book.
Yeah,
Go ahead. Sorry.
I would say it is one of those things that you finish extensive neurosurgical training, and oftentimes neurosurgical programs just don't provide this level of insight. And it's one of the most practical things that you need is how to build a practice and to do what Rick's done so nicely and what you've outlined in the book, I think is something that isn't necessarily second nature to everyone. And there are things that I as I read the book, I mean, I thought, wow, this is the first time that someone's really consolidated these aspects, many of which, or some of which it took me years to sort of figure out, well, if you do this, it has this benefit in terms of patient care, or this benefit in terms of practice. But Rick and Dan, what's your sense of, if you you break this into chapters, describe a little bit about the organization of the book and kind of what you see as the critical pearls of the book, if you're going to give a synopsis.
So I think that one of the main focuses is that you're building a practice not to increase your fame or ego or anything. It's really to improve patient care. There's a lot of really high profile papers that have shown something called the volume outcome effect, which suggests that surgeons that have more surgical experience in more cases tend to have better outcomes. So we start the book with that perspective, with the idea that your best advertisement for yourself is patients with great outcomes who tell their friends that they had a very good experience with you. So we talk about how to have great patient outcome, great clinical outcomes, and avoid complications. That's where we sort of start the book.
Yeah, I mean, that's exactly right. What Dan said is that I think that when you finish residency, you think that the operating room is the most important part of your job. And it is, obviously, that's where you're taking care of patients. But what's very clear the moment you leave residency is that if you only work in the operating room and outside the operating room, you don't put in the effort that we describe in the book, then you'll never be successful, because there's so much more, or at least you won't hit your entire potential, because there's so much that goes into neurosurgery outside of the operating room that is never really discussed, that most residents have no idea about. And until you're out there as an attending, you really don't realize how much work goes into what you do outside of the OR. And that's what's critical.
We, Rick, yesterday you and I were chatting, last night about sort of how you keep a patient from, say, they come to see you with a brain tumor, and how do you avoid losing that patient to somebody else, especially when you're in a metro area, it's competitive. Miami is a massively, I'm literally staring at it right now. It's a massively competitive market with, people everywhere. How have you over the last decade sort of established this? I mean, there's obviously a secret recipe that you've outlined in the book. And I don't want to give away too much, but how have you managed to pull this off for, your centers? I mean, you alone are doing almost 700 brain tumors a year. It's kind of outrageous and amazing.
Yeah. So I would say that, a lot of it is reputation. So there's the early part in your career, and then there's the later parts in your career once you've already developed a reputation. Once your reputation is formed, it's a lot easier to keep patients, because people will come to you under the understanding that you are the best at what you do, or one of the best at what you do, and the best option, and the amount of can do it, really becomes minimal. And my fellows will also comment that early on, my first 5 years, it would take me 20 or 30 minutes in a room to basically explain to a patient why we were operating, what are we going to do, and make sure they felt comfortable. My current clinic, it's like a 30-second discussion, because they're basically like, whatever you want to do, doc, whatever you want to do, because they've come to me with the understanding that there's a reputation behind what you're offering and the program excellence. So my recommendation would be, for residents and for fellows, you got to spend time with high volume attendings. And as I told Nitesh yesterday, just because someone comes to your office with an operative tumor doesn't mean that you're going to do the operation. You have to convince them that you're the person to do that operation. And the way to learn that, obviously you're going to learn it on your own, but it's to spend time with high volume attendings who have already perfected that trade and kind of know how to describe the case, how to make a patient feel at ease, inspiring confidence. There's no recipe for that. It's really an art to be able to portray confidence and security to a patient such that they're going to let you open up their head.
Yeah, well, I mean, it's always an honor to take care of patients, neurosurgical brain and spine patients, that's for sure. And it's it's amazing what they entrust upon you to, as you said, to let someone open up your head and or your spine and do a complex procedure. One of the things that I think is interesting about the book is your talk about social media. I mean, we're on a social media platform now talking about typically articles and new research and things like that. But how has social media changed the way neurosurgeons interact with patients, referring physicians, and colleagues?
Yeah. So I would say that social media has moved from being something for kids, something for fun, to being a major avenue for business revenue and marketing and PR. If you look at the number of people under the age of 50 or 60 that are on some form of social media, Instagram, Facebook, Twitter, it's like 80-90%. And so if you think about it, you just have to remember that anytime someone gets referred to you, doesn't matter who they are, for the most part, they're going to Google you and they're going to check you out on either Instagram or Facebook or Twitter. And so, I think the sooner you realize that social media has become and will always be the face of your practice, people need to look on social media and see something that tells them that you are a good surgeon with good outcomes, who is up to date, doing cutting edge research, doing cutting edge techniques. And so social media has gone from being a pastime to being almost required if you want to be competitive in a major market. Because again, patients don't know who a good surgeon is unless they are a doctor themselves. They get referred to you, so they're going off of that. But other than that, they don't know what a good surgeon is. And if someone's social media and someone's website looks like crap, they look at it as being like, well, why doesn't he have a better social media? Why aren't his articles listed on Google? Why doesn't he have, a good presence? And I think that patients really seek that nowadays.
Yeah, it's interesting. I mean, you've said a couple of things throughout this webinar so far that brought back some memories. One was a comment by Laszlo Steiner, who told me at the onset of my career, he said, the best marketing is no marketing. I disagreed with him at that point. But it was amazing at the time. It was true. I mean, when there were only 5 Gamma knives in the world, you could write a few articles and sit back in Charlottesville and patients would come to you. And he had a great reputation. He was a master surgeon. But, as there became 130 plus radiosurgical units in the country, or Gamma knife units, not including LINAC-based systems, suddenly the competition changed and the dynamics really changed. And you need to be reaching out and putting your message out there. hopefully, it's a positive one that resonates with patients. And then Ed Oldfield told me years ago, he said, that it's hard to become famous in neurosurgery. You really, if you think about who's the most famous neurosurgeon, is Harvey Cushing. But if you walk down the street, you asked 100 people who Harvey Cushing was, I'd be surprised if you got one or two people that would know who he is. If you didn't happen to run into a neurosurgeon or weren't at the AANS or CNS convention. But I think that people know who you are, Dan, Rick, and they know that, I think, through your interface with patients and the social media that you put out there. So I think that you're not really looking to be famous like a pop star might be. You're looking to get your message out there, and I think that's how you use social media. Some influencer or social media star may make $100,000 a post, but that's not what your aim is. You're not, So I think that's the critical message. It's social media for the better of the patients, better of the care, and obviously to build your practice. And you've done that. You outlined that very nicely in the book.
Yeah, I think patients are getting much savvier, much more informed, and that's all great things. And a lot of that has to do with the internet and social media. And there's just more opportunities for them to learn about different techniques or different surgeons and whatnot. So we're not really necessarily, saying to do anything shady, but just to put your work out there, your good outcomes, your papers, things like that. And that's another data point for the patient to decide who the best surgeon is for them.
And there was this perception, and I think Dr. Steiner, coming from a different generation, had noted that maybe you really shouldn't be out there. You shouldn't be putting your name or, God forbid, you're not putting yourself on a billboard or anything like that, but you're getting that message out there in a professional, consistent fashion. And I think you're right. It's hard for patients to know who the good doctors are for a specific condition, much less a general condition like a brain tumor, but even a specific type of brain tumor or location of brain tumor. And so what better ways do they have to do that than interfacing with their local and referring physicians? But also it's so common now for patients to get on the internet and to search you and to see what's out there on you. And you want to make sure that that information is your brand is correct and clear, and hopefully you seem like an approachable person. So one other question which I had as I sort of read through the book, and and this is likely evolved, but how much of the practice in 2021 for Miami neurosurgeons do you think is coming from direct patients seeking you out versus referring physicians or internists, PCPs, ER docs? How many people come to you for because they found out about you maybe from a friend or through their own internet searches versus coming through a standard traditional physician channel?
So I'll even break it down further. I'll say there's three categories. There are people that come to the university for the university, and then they get delegated to you.
Right.
Then there's people who get referred to you directly, not the university. And then breaking down those direct referrals, there is, a doctor referral to you, and then there's word of mouth or what have you. I would say university referrals, at least for me, is minuscule. It's well below 5%. I would say. I can't remember the last time I saw a patient who came to the university and then got directed to me. The ones that get directly referred to me, the breakdown is probably 3/4 from a physician, at least, meaning that they saw a doctor who I worked with before, who knows the work we do, and they've referred that patient to Rick Komatar. Then there's about 1/4 of the patients that, a friend of a friend you operated on, or I saw you on the internet or what have you. That's probably about 20-25%, I would say.
It's interesting what you said too, is that, as we look at these broader health systems, there's this perception that that the physician, that the referrals are coming to the health system, when in fact I oftentimes think, as you've just attested, that the referrals are coming for the physician who just happens to work at that hospital, and that if you look at neurosurgeon A versus neurosurgeon B, they're not necessarily interchangeable in how they might establish and maintain and build and grow referral patterns. And I think you touch upon that too, in terms of making sure that your practice has the resources it needs, as you know, from the institution that you're practicing in, because they're benefiting from this and the patients you bring in. And there also is this tremendous halo effect that my guess is that patients may come to see you, but then they may come to see other colleagues, both in neurosurgery and radiology and radiation oncology and neuro-oncology and neurology. You might not even operate on them, but they've come to see you, and that's the, sort of that recipe that you've got to make sure that the institution understands that, so they adequately resource you. So you've got the clinic resources and the OR resources and all that you need. I think your book describes that process pretty well.
On that same token, though, sorry, Dan, just one last, I wanted to add to Dr. Feen's comments there. On that same token is that, there's every industry we look at, whether it's electric cars or whatever it may be, there's always a front runner. And the front runner is not necessarily based on just quality alone. It's based on customer service. And since we're going to call it the business of brain tumors, and we typically avoid the word business in the medical sense, but it is a business at the end of the day from that aspect. Sort of customer service is something I wanted to talk to both Rick and Dan about, especially from Dan's perspective, from a resident perspective, because it's something we don't necessarily think about always in residency. But if you guys can touch on that too.
Yeah, absolutely. So I think there's two aspects to that analogy. So number one is making patients feel that they're cared for. And, obviously, first and foremost is having excellent clinical outcomes. But number two is just having a relationship with the patients, rounding on them twice a day, taking the time to sit down and have a conversation, understand their anxieties and what their concerns are. So I think that goes a long way. Even in patients who have a complication, if you spend the time to explain what you're going to do to fix the complication, a lot of times, they're aware that, surgery is risky business. There's always a risk of a complication. But if you take the time to guide them through that complication, that really goes a long way with them. So that's one aspect of it. And then the other aspect is keeping the referring physician up to date. So we're not the only, as neurosurgeons, we're not the only physicians taking care of these patients. They may have an oncologist, a primary doctor, an ophthalmologist, and these other doctors also care a lot about the patients as well. So it's important to keep them in the loop, let them know what the plan is, let them know that surgery went well, let them know what the follow-up is. And the referring doctors really appreciate that. A lot of the time they haven't been called by other surgeons before for an update. And that goes a long way towards having them send future patients to you.
Simon,
I just wanted to
go ahead.
I just wanted to go back to what Jason was saying originally, that what the book points towards is the traditional battle that goes on that I'm sure Jason knows about. It's the university academic setting versus the singular surgeon, meaning that the university tries to make websites very plain, very traditional. They limit your templates because the university wants to make surgeons interchangeable. They want it such that if Jason leaves the next day, the next person comes in and nothing is lost. The same with me. And they really envision surgeons as interchangeable when obviously we're not. And so what you want to do as a surgeon is you really want to create a brand. You want to create a reputation, an image, a brand such that the university doesn't control you anymore. And that's very difficult to do. But the principles of the book basically tell you how you can build a brand, how you can take control of that patient population. And one of the big things about my talk is that if you control the patient population, meaning if those referrals are coming to you and not the university, you now have control. If they're coming through the university and you don't work on a brand and you just wait for the university to trickle down a couple of referrals here and there, you've got no control. And the university owns you and they can tell you what to do and you have no leverage. If you control the patient population with the halo effect and how much comes from downstream revenue of these referrals, now you're in the driver's seat. And if you want different equipment or different OR time or different resources, you have that leverage over the university. But that's a very traditional battle that goes on at any academic center. They don't want surgeons to be individualized. They want you to be interchangeable, which is obviously different than what surgeons, will aspire to do.
Yeah, I agree with you in that it is that constant sort of tug back and forth. But the interchangeability of surgeons, I've seen, those who do or don't follow some of the principles in your book, the surgeons are not particularly interchangeable. I mean, their personalities and likes and dislikes in terms of case preference and volumes are oftentimes radically different. So, Simon, you've been quiet, and we'll just pull you into the conversation here towards the end. I apologize, but you did a fellowship in Miami. You're now up at Westchester Medical Center, I believe. And tell me, you were editor or one of the editors of this book? Are the principles outlined in the book, do you feel pretty consistent with what you see as a practice building opportunity in New York? Because I certainly saw those as being valid, in my area, my geographic area of Virginia. But talk a little bit about that, if you mind.
Yeah, absolutely. I mean, I was Rick's fellow going on 7 years ago, and very close with Rick, watched him, really shadowed him very closely to learn that aspect of his practice, the art of practice building. And then obviously he's an extremely close friend of mine, and we maintain constant communication. So yeah, I mean, I've definitely applied these principles in the book to the best of my ability, and you see the fruits of that labor. I mean, there's no question that when you go about it this way systematically in terms of communicating with physicians and following up and all the emphasis and good outcomes, you definitely see the product of that. I mean, you definitely see your practice build and develop. Ways in which I think Rick and Dan have taken it to another level since I was there were really kind of the embrace of social media, which has always been kind of a controversial issue for physicians for various reasons historically, like the neurosurgeon you mentioned. There's been this aversion or resistance to marketing yourself. You should kind of be above that in the world of medicine. But that's just kind of out the window now because there are all these competing healthcare systems, and marketing and getting your message out there is essential now. You can't really avoid that. One thing I think that I've encountered that's made the sailing a little bit rougher has been the consolidation of healthcare systems and these mergers. And it's something you were touching upon a little bit before. It'd be interesting. I know we don't have that much time, but to hear what Rick and Dan have to say. When you have private practitioners out there who kind of don't know where to turn, kind of corralling them and convincing them and proving to them that they should send you patients is a little bit more straightforward. But now when that physician group or that physician individual is now partnered with a rival healthcare system, which is a lot of what we're seeing nationally, and especially in kind of the greater New York area where I practice, it becomes a little bit harder. They may love you. They may want to send you a patient. They may used to send you patients. But now they're part of a different system, and they're really told, in fact, watched to see whether or not they're keeping their referrals within the system, not just neurosurgery, but oncology, et cetera. And it's a harder thing to combat as that stuff has kind of consolidated. So I'm just wondering, what tips the authors have about that phenomenon. And Jason, you as well.
No, it's a great point. Rick, Dan, what are your thoughts?
Hey, Dan, you want to take that one, or?
Sure. I mean, it's definitely a challenge. I mean, it also kind of depends on the resources that the hospital has, but there are some sort of plans that, like, especially in like managed care settings, like bundles that you're able to do to entice people over. But I would say that like some aspects of that are you can't overcome them. But I think a lot of the, lessons and stuff in the book are still useful. And like, you have to just do the best that you can and try to go around those things.
Yeah. So, I mean, just to expand on that, I would say, just like Dan said, you can definitely have carve outs, insurance carve outs, because tumors are relatively rare compared to other conditions that the hospital treats, like appendectomies or what have you. So what we did early on was we worked with the hospital to form carve outs such that even though the hospital or the university may not take insurance A or X or whatever, we work and say, fine, maybe you don't take insurance X for cardiac disease, which maybe is pretty common, but for brain tumors, you'll do a carve out and you will accept that insurance. So you have to work with the hospital to hopefully get some carve outs. We haven't carved out every insurance. There's certainly insurances which we don't take, but there's a lot of insurance that the university doesn't take or the hospital doesn't take. And we have, through volume and through proving that our outcomes are better, fewer readmissions, fewer complications, shorter hospital stay, put that data together, show the insurance companies, they're going to want to work with you because you're saving them money compared to some person at a private hospital who maybe length of stay for a case is 4 to 5 days, readmission rates much higher than yours. If you can prove that, the insurance company is going to want to work with you. So we got carve outs during our first couple of years. And then if you really don't take the insurance and it's a symptomatic tumor, send it through the ER. There's nothing wrong with that. If it's an asymptomatic tumor, that's a little bit different. But there's numerous times where I'm referred a case and I see the films and it's a large tumor, patient has a neurological deficit. We don't take the insurance. I say, come to the ER. There's absolutely nothing wrong with that because the person has a symptomatic tumor. You are the best at taking care of. You're doing what's best for the patient. And they come in to the ER and that should be covered by their insurance because they're symptomatic.
I'm gonna just say completely agree. I mean, I think those carve outs are critical. And that you've got to be at the table with your hospital when they're discussing contracts with private payers, or at least they should be consulting you, because the brain tumor operations that one performs and adjuvant therapy and other sorts of things, they're not that commonplace. I mean, you're not talking about the care of for otitis externa or otitis media, where you got an E&M visit and some antibiotics for the most part. So, I mean, these are very expensive procedures. You want to make sure they're done well, and hopefully want to avoid the complications and readmissions rates. Well, my plug is, hopefully this book's going to head to the Oprah Book Club or something. That's my my goal for this webinar. Nitesh, your final thoughts?
Yeah, so I just want to thank everyone for tuning in today. Dan and Rick, thank you so much. Simon, especially you last minute coming in, and Dr. Sheehan, of course. One thing I definitely want to sort of save as a teaser for everyone out there listening today. Having been trained by Simon Hanft and being Rick's current fellow, one of the things that have been emphasized to me that we didn't necessarily touch upon too much was we talked about surgical excellence and customer service, but sort of building a culture of excellence, a team building. It takes a lot more than just you as a surgeon or as a provider to create a brain tumor program or a program of anything. And, I firsthand experienced that with Simon Hanft, who was at Rutgers during most of my residency training. And, have knowing Rick for quite a few years now, I will say that, I'm looking forward to learning more about that today. And I think that's pretty well explained in the book. There's a large portion of the book dedicated to that. So I recommend everyone go on Amazon, buy it. I'm not sure if the Kindle version is still free. Buy it, leave a review, and I think it's very valuable for everyone.
Thanks everyone for joining, and I concur. It's great, many pearls in there that took years for most of us to realize. Thanks for putting this together and joining us today. Okay.
Thanks everyone.
All right, guys, thanks for having us.
Take care.
Take care.
Take care, guys.